So as I mentioned before, nephrology of the subspecialty, which is need educator, someone to guide you. If you didn't have a guidance in nephrology, especially in glomerulonephritis, you will be like Attar, giving some red medications and yellow medication and wish the patient get treated. You have to read, but also you have to get someone to guide you, especially as I mentioned in glomerulonephritis. And I was lucky to have this professor guiding me, and he is extremely sick now. So I wish everyone to pray for him. Yeah. So I will start my presentation with two case scenarios. Case number one is 25 years old male patient came to the emergency with creatinine 600, GFR almost 8. He has no previous history of any medical disease, and he never went for a checkup. He was about to do teeth extraction, and he did a routine labs, showed abnormal kidney function, and their dentist advised to go directly to the emergency. Family get panicked and start to ask you multiple questions, like, does he need dialysis? If yes, is it lifelong dialysis? And some smart of the relative, he start to ask, does he need to do a kidney biopsy? And you get trapped. Case number two, you have 24 years old male patient presented with acute onset of generalized edema with progressive course. Urine analysis showed albumin +3 and no RBCs in urine. His creatinine is 0.5 milligram per deciliter. And now, what is your approach for such a case? Investigation do you want to ask? Do you need to do a kidney biopsy for this patient? What is the expected pattern in histopathology if you are going to do a kidney biopsy? What do you think about the most important microscopy? And please write a referral for pathology asking for diagnosis or of your suspicious. So we have two cases. We'll go one by one. So today's session, I will speak about three main parts. So number one, I will speak about kidney. I will speak about patient. I will speak about our investigation, and I will start my presentation with investigations. The question number one, does this patient he need dialysis, and how can we use our tools in investigation to diagnose if he need dialysis or not? This is the simplest question in our presentation now. We have usually absolute indication for dialysis, like volume overload, hyperkalemia, acidosis. So to answer such a question, we need to go through these labs and to assess patient clinically if he has some kind of absolute indication for dialysis, like as I mentioned. All of us know the absolute indication for dialysis, so we will initiate dialysis. The most difficult question to answer is the timing for initiation. Do we need to start early? Patient now GFR around 8, so we can start dialysis. Either he has absolute indication for dialysis or not. The late indication, it's mean late initiation. I mean, we wait until the patient is indicated for dialysis, like volume overload, hyperkalemia, and acidosis, and we initiate upon an indication, not for advanced kidney disease or advanced low GFR. So it's still debatable. It's individualized decision. Sometimes you consider this patient will improve, and especially if the patient showing some parameters of improvement, and you're considering as acute kidney injury, so you prefer to wait. And if the patient doesn't have absolute indication for dialysis, you'll consider it late initiation. And sometimes you give up from your patient and consider him as a chronic kidney disease and his advanced kidney disease. You prefer to early initiation of dialysis because you don't want to expose your patient to complications. So for the first question, family are asking you regarding the initiation of dialysis, yes or no, you have to look for absolute indication and you have to wait your decision if this patient is indicated for early or late initiation of dialysis. So regarding investigation, as I mentioned before, usually we have laboratory investigation like urine, We have serology like renal function test like urea, creatinine clearance, electrolytes, ABG, immunological screening, virology, complement system. We have a lot of radiological assessment like ultrasound, CT with contrast, isotopic scan. We have special investigation like renal biopsy, fundus examination. We have in transplantation, we have the immunological workup. This is the nephrology investigations. So the second question is, does this patient need lifelong dialysis? And this is also an easy question. To answer, you have to look for signs of chronicity. What is the signs of chronicity? You are looking for parameters that indicate this patient is advanced kidney disease like CKD, MBD. You can see if the patient has hyperparathyroid, have low calcium, hyperphosphatemia, if the patient has anemia, unexplained, because sometimes there is a mixed, confusing picture. Like let's say, some patient has primary hyperbara, which is complicated with the stones, and patient develop obstructive uropathy. So it's not a generalized rule, but you have to look for it. And also you have to use ultrasound. You have to look for the kidney size, shape, echogenicity, and corticomedullary differentiation. And you can do special investigation like fundus examination or biopsy for confirmation. So simply, for this patient who came to the emergency with creatinine 600 for around 8, I will answer the family question about the lifelong dialysis after looking for this chronicity, like as I mentioned, PTH ultrasound and special investigation like fundus examination. Fundus examination is unfortunately one of the missed tools in our subspecialty, and it's very important. And I advise all of us to start to practice it in our clinical practice every day. By fundus examination, you can diagnose a lot of diseases like diabetic retinopathy, hypertensive retinopathy, which is related to reflect on our kidney with diabetic nephropathy and hypertensive nephropathy. Also, you can see one of the most common Holland forest plaques, which is usually seen in atherosclerotic renal disease or Ross spot, as we see in our picture. It's related to infective endocarditis, CMV retinitis, and CMV also related to invasion of the transplanted kidney, usually seen by fundus examination. A lot of diagnosis can be done by fundus examination. It should not be missed. So I'm encouraging you all to start to use this tool in our daily practice. About kidney biopsy. This is the most confusing question, and it's usually we get a referrals from periphery about a patient asking for kidney biopsy, acute medicine asking us about a patient need a kidney biopsy, and the primary workup for kidney biopsy, it's usually not done, because most of us doesn't recognize that the decision of kidney biopsy is usually based on urine analysis. And this is, unfortunately, the most important information of this presentation. And we have to remember all of us. So regarding the decision of urine, kidney biopsy, we have to look for urine. We have to look for proteinuria. We have to look for hematuria. How come we can make this decision by this simple tool? I will show you. Regarding number one, hematuria, we have two kinds of hematuria. We have this dysmorphic RBCs. Dysmorphic RBCs, as you see in this picture, the RBCs showing some kind of projection. This projection is what is called the acanthosis. This is caused by trapping of the RBCs in the glomerulus and the tubules. We have, on the other hand, what's called the monomorphic hematuria. This, as you see in the picture, it's a biconcave RBCs, normal in shape. This is usually seen in patient with extraglomerular cause. As we see also in this table, we have dividing our hematuria to two main categories. Extraglomerular hematuria, this is a monomorphic hematuria. This is related to urology, emergent malignancies, and this is not related to nephrology. On the other hand, we have the glomerular hematuria. As we see, this is a dysmorphic hematuria. This is electron microscopy picture showing again RBCs with this acanthosis. This is a dysmorphic RBCs. This is the normal shape of by concave normal RBCs can be seen also in hematuria. So this is the first important topic, hematuria. Now, the second point, proteinuria. Proteinuria, it's a big issue. We have to go through it. I will start with a physiology, unfortunately. Renal protein excretion is determined by three main factors. Number one, the protein characteristics, like its size, concentration. Number two, it's related to glomerular permeability. Number three, it's related to the tubular reabsorption. So the smaller and the more positive charge protein has a greater affinity to be filtered in the urinary space. On the other hand, the large and the more negative proteins, unfortunately, it can't go the glomerular filtration rate. So normally, if you have normally we have 1 to 3 grams of protein, approximately 2/3 globulin and 1/3 albumin are filtered daily. But over 90% of this filtered load reabsorbed by the tubules. So the end result, it will be 150 milligram of protein is maximally excreted each day. And this protein, it's called the 10-horseful protein or uromedulin. And this is the one which is responsible for formation of cast. This is, you can imagine protein in the tubules like this metal iron using in casting and manufacture. So for detection of protein, we have the regular one, which is the dipstick. This is it can be differentiated to a single urine sample like dipstick, sulfoline, salicylic acids, albumin creatinine ratio, or protein creatinine ratio. This is using a single urine sample, or we have the 24-hour urine collection. Also, we can divide it the same labs, but in another category, we can use it like semi-quantitative method, like a standard urine dipstick, presentation of urine using a sulfonine salicylic acid, sulfosalicylic acid, or quantitative measurement like 24-hour urine protein creatinine ratio, albumin creatinine ratio, and we have another tool which is called the estimated albumin filtration rate, excretion rate, and protein excretion rate. So simply, either using a single urine sample or 24-hour, or we are going to use it another differentiation or categories to semi-quantitative method. It's going like we can see the standard urine dipstick giving 1+, 2+, 3+. It's a semi-quantitative. But the exact amount of excretion, it needs this 24-hour or protein create, albumin create as a quantitative measurement. So regarding the standard tool, which is the dipstick, it's a very valid tool and is still used in our clinical practice, but I want to focus on a small point. There is a causes for false positive dipstick. This can be seen in our clinical practice. This is usually seen by after hydrogenated contrast, or in a patient with highly alkaline urine, or a patient with gross hematuria or bus cell, because he knows the dipstick, it can't differentiate between the protein in the RBCs or bus or the proteinuria itself. And sometimes by using a specific antiseptic substance. So you can imagine sometimes we get a referral for a patient who might need a kidney biopsy based on dipstick. And when you ask the patient, you found he has some kind of UTI, or female patient has menstruation, and this dipstick is false positive due to the gross hematuria and bus in the urine. So be cautious. Dipstick is valid, but you have to look for the false positive causes. So for quantitative measurement of protein, we have, as we mentioned, 24-hour versus spot urine, which is preferred. 24-hour is the gold standard. And as we know, the normal value is less than 150 milligram per day. The main issue regarding the 24-hour is the major limitation regarding collection. And some difficulties regarding some patient, you have to educate him how to collect the 24-hour. But here is a tip for you. Once you ask for 24-hour urinary protein, ask for 24-hour creatinine excretion also, both of them together. And I will tell you why. Because you want to confirm this patient did the collection in correct way. So simply, If the patient did a collection 24-hour and you estimated his weight, let's say his weight is around 100 kilogram, so you are expecting a creatinine in his urine around 2,000 or 2,500. If the creatinine amount in his urine is less than this amount, you consider this patient to collect incorrectly. So it will help you to differentiate between patient did it right or did it wrong. So please, if you're asking for 24-hour urinary collection, protein excretion, ask also in the same time for creatinine excretion. For urine sample like protein creat ratio and albumin creatinine ratio, it's a very valid tool also. It has its advantage because it's a spot urine, usually first or second morning sample. The main issue regarding protein creat and albumin creat is the scale. Sometimes it's milligram per deciliter, sometimes it's a millimole, sometimes a milligram per millimole, milligram per milligram, milligram per 24-hour. So be cautious about your decision about this amount of proteinuria because the scale is very important. You can imagine for urine albumin creat ratio of 30 milligram per gram creatinine, it's equivalent to 3.4 milligram per millimole creatinine. So if the scale is different, you will get more confused. And I advise you to, for myself, I'm converting all of the amount to 24-hour. If the patient have like 3.4 milligram per millimole, I will convert it to the 24-hour just to make it simple for my mind. And the advantage, it's easy to be used. Both of them approved by the CODICO guidelines, but as we mentioned, it still have some kind of limitation. We all see in Royal Hospital, sometimes the patient has the same amount of proteinuria, but unfortunately, creatinine is started to increase in the urine. Creatinine in this equation is the dominator, so it will reflect with negative impact on the protein creat ratio. You consider it as an improvement of worsening, but actually the same proteinuria, but the difference is the urine creatinine concentration. So again, there is a lot of limitation regarding this tool. It's valid for follow-up, but it's not valid for decision-making, especially for major decisions, like change of management or to go more aggressive or something like this. And I will approach this point later. So just to give you imagination how it's difficult, you can see this is normal excretion in 24-hour. Usually albumin is less than 30 milligram per 24-hour. But if you compare, if the patient has microalbuminuria, it will be from 30 to 300 milligram per 24-hour. And if macroalbuminuria, it will be more than 300 milligram per 24-hour. This is for milligram per millimole, and this is for 24-hour. You can see less than 3 equal to 30 milligram per day. But for microalbuminuria, it will from 3 to 30. It's equal to 24 hours from 30 to 300 milligram per day. If you are using dipstick and giving you 1 plus, 2 plus, 3 plus, it's equal to more than 300 milligram per day. But if it's more 3 plus, it's usually 1 gram. And if 4 plus, usually it's a nephrotic range or more than 200. So again, don't get confused regarding the scale. Use whatever you want, but try to convert it to a simple one you're understanding well. And this is also the difference between protein creat and albumin creat and switching to 24-hour. So you have to focus, is it albumin creat or protein creatinine ratio? And what is the scale? It's milligram per millimole or milligram per milligram, milligram per gram, gram per day. It's a little bit confusing. We have another tool which is called the albumin excretion rate. It's also a valid tool. It's approved in 2014, and it's contain a lot of confounders just to make sure the patient gets the accurate number. And it's using age, sex, race, like the equation of creatinine clearance. We are using switching from Cockcroft to MDRD to CKD epidemiology. You are just asking for more parameters to make sure you are getting the more accurate results. So how to approach evaluation of proteinuria, case of proteinuria. Usually, this is the advice from up to date. They asking for 24-hour urine collection to be done for initial evaluation. And in the same time, you're asking for 24-hour protein excretion, you have to ask for creatinine excretion, just to make sure the patient made the right collection. And in the same time, you have to ask for the spot urine diagnosis like albumin create or protein create, just to compare between both of them. And for follow-up, you can use whatever you want, albumin create, protein create, whatever your decision. But once you are going to change your management, it's better to go back for the gold standard, which is the 24-hour urine collection again. This is from up to date. So it's a difficult question, difficult decision, but you have to do it. Here, I'm just mentioning there is a lot of causes of proteinuria, like transient proteinuria, persistent proteinuria. I don't want to get you more confused, but I have to just to focus on one issues. Glomerular proteinuria, it's usually nephrotic range. This is the source of, once the glomerular lesion is the cause of proteinuria, usually it will be nephrotic range. But for tubular interstitial, it can cause proteinuria, but usually it's less than what's in nephrotic range and never exceeds 3 grams per day. So again, our nephrology investigations, we mentioned before, we have urine, serology, radiology, and special investigation. And to differentiate between glomerular disease and non-glomerular disease, we have to look for the urine. If the patient has nephrotic range proteinuria, this is a case of glomerular disease. If the patient have subnephrotic proteinuria, so he maybe have a glomerular disease, but still it's cooking, not reaching the nephrotic range, or maybe subnephrotic, it's related to a tubular disease. And if the patient has dysmorphic RBCs finished, this is a glomerular disease also. If the patient has RBCs cast, this is a glomerular lesion. So again, decision of kidney biopsy for diagnosis of glomerular disease is based on urine analysis. Don't forget. So at the first of my presentation, I mentioned I will go through 3 main categories: kidney, patient, investigation. We finished our first part, investigation. So we will go for patient. We have what is called the clinical syndrome in glomerulonephritis. What is the meaning of clinical syndrome? Clinical syndrome, it's just clinical prescription. It doesn't reflect a specific disease. It's just prescription of what we are seeing clinically. So we have a patient came to you coming with hematuria, coming with proteinuria asymptomatically, has no symptoms. He just accidentally discovered to have some kind of hematuria. We have what is called the nephrotic syndrome. We have what is called patient came with acute kidney injury in the form of nephritic syndrome up to he need dialysis. So what known cases of clinical syndrome? We have 5 main categories. We have what is called the asymptomatic urinary sediment. This means the patient, he was doing some investigation and someone diagnosed him with some kind of proteinuria, hematuria, but actually he doesn't have any problem. He was accidentally discovered. We have also what is called nephrotic syndrome. This patient presented with generalized edema, proteinuria, nephrotic range, hypoalbuminemia, edema, and hyperlipidemia. We have also what is called the nephritic syndrome. Nephritic syndrome patient came with hematuria, advanced kidney disease, azotemia, hypertension, and edema, may or may not requiring dialysis. Rapidly progressive glomerulonephritis is the advanced process of nephritic syndrome. Patient started to deteriorate rapidly over days or weeks, with or without proteinuria. And finally, we have what is called the chronic glomerulonephritis. This means a patient came with advanced kidney disease, missed, he didn't diagnosed as a glomerular disease, and now it's too late to diagnose what is the primary, mainly underlying kidney disease. So we are labeling him as a chronic glomerulonephritis because we can't know what is the underlying kidney disease. So these 5 main categories should be clear in your mind, because once you are seeing a patient, you have to categorize him to one of these main 5 categories. because it will reflect on your diagnosis later on. So we have what is called clinical syndrome. Clinical syndrome, as we mentioned, it's a 5 main clinical syndrome, which is reflect on a pathological diagnosis, which is also a pathological pattern, not a disease. And finally, we have to diagnose what is the underlying etiology. For the clinical syndrome, we have this main 5 categories: asymptomatic urinary sediment, nephritic and nephrotic, rapidly progressive glomerulonephritis, and chronic glomerulonephritis, which is reflect on a pathological disease, which will affect one of the compartment, glomerular, tubular, interstitial, and vascular. And finally, we have to diagnose what is the underlying etiology. Is it primary or secondary? For example, we have clinical syndrome like nephrotic syndrome. Usually the underlying pathological diagnosis, it will be a glomerular disease affecting the glomerular filtration barrier, which is mainly the podocytes, the epithelial pattern. And we have to diagnose, is it primary or secondary? Like we would say FSGS, we have to know what is FSGS, primary or secondary, membranous, primary or secondary, because it's a different identity. So it's once you are getting the diagnosis of membranous nephropathy, it's a pattern. Primary membranous disease, it's a disease. It's another issue. So clinical syndrome, it's just a clinical prescription. Pathological, it's just a pattern. Etiology is the disease itself. So how many patterns we have? We have the epithelial pattern. This is the disease affecting the glomerular filtration barrier, and usually present with nephrotic syndrome, and usually diagnosed by electron microscopy, because this is the main one which is able to look for epithelial basement and basement membrane. Regarding the endothelial pattern usually present with rapidly progressive or nephritic syndrome, rapid decline in GFR, and this is the underlying cause, and usually diagnosed by light and immunofluorescent. So we have also the mesangial pattern. Mesangial pattern, it means this disease affecting the mesangium, like IgA, IgM, and this mainly diagnosed by immunofluorescent microscopy, as we will see in the pathology. So we have the main categories of glomerulonephritis. We have proliferative disease, proliferative glomerulonephritis, non-proliferative glomerulonephritis. Non-proliferative, this means this patient will present with mainly nephrotic syndrome without cells, a lot of cells in the histopathology, like minimal change in membranous FSGS. We have also what is called proliferative pattern of glomerulonephritis, which usually present with RBCs, hematuria, and patient with dearranged kidney function and may or may not require dialysis. And this proliferative pattern either mesangial or endothelial, like we will see in the histopathology. I would like just to focus on another point regarding treatment of glomerulonephritis. Patient with blunt urinary sediment. What is the meaning of blunt urinary sediment? This patient was presented with normal GFR, just proteinuria, glomerular lesion, yes, of course, but he doesn't have RBCs. He doesn't have any rapid progression in his GFR. This is considered what is called the blunt urinary sediment. The underlying pathology, it will be non-proliferative lesion. So usually these cases are called the cases. You can electively admission. Treatment, usually we have to wait until we get the underlying disease. On the other hand, if the patient has active urinary sediment, what is the meaning of active urinary sediment? Patient has RBCs in urine. So if the patient has hematuria, rapid decline of GFR, abnormal GFR, even with normal GFR, once we have dysmorphic RBCs in urine, this is an emergency. Patient usually have proliferative lesion, and this patient needs to be admitted right away. And treatment, you can individualize. Some patient, you can start electively with pulse steroid until you get the result of biopsy. And sometimes you have to wait, or you can wait. And it's not a unanimous decision. You have to wait everything, and you can discuss with your patient. But again, if some of us just starting treatment for a patient with nephrotic syndrome, pulsing steroid, this is too much. And regarding even admission, it's an elective admission, by the way. Don't get confused, because sometimes we get a referral from periphery for a patient with nephrotic syndrome, and we put an elective OPD appointment after 1 month, 2 months. Don't get panicked. This is acceptable. Not too much to 2 months, but maybe it's an elective admission, elective case. So again, don't forget, we have two main categories now of glomerulonephritis: proliferative changes, non-proliferative changes. Non-proliferative changes usually present with blunt urinary sediment, usually nephrotic syndrome, without abnormality in GFR. And regarding proliferative lesions, it's either mesangial or endothelial. And usually this is an emergency and need to be admitted and need to be urgently treated. So the final part of our presentation today is histopathology. I keep it to the end. I will not make it hard. I will just go quickly. So histopathology, we use this needle for doing a kidney biopsy. This is the glomerulus. We have to look at after taking the kidney biopsy. After kidney biopsy, we are dividing the core to three main categories, three main parts. The middle part, it's usually for light microscopy and immunohistochemistry, because this is paraffin. Paraffin, it's like wax. For electron microscopy, we are using formaldehyde. No, we are not using formalin. We are using glutaraldehyde. And for immunofluorescent, we are using a fresh sample. So previously, we was not using this immunohistochemistry. The advantage of immunohistochemistry over the immunofluorescent is it's frozen paraffin section. Paraffin section, it can maintain for a long duration, so it can be even examined after years. But for immunofluorescent, it's fresh, so it can get ruined after time, and it can't be seen after a few months. Some centers, like I'm showing you in the picture, dividing the sample, the upper part, which usually contain the glomerulus, usually for electron microscopy. The second part, which is the large one, is for light microscopy and immunohistochemistry. And the last one, which is the third part, it's usually for immunofluorescent, but it's done by histopathology, not by us. This is the normal picture. As you see, this is glomerulus, renal corpuscles, and tubules, and there is amygdala and blood vessels. And to say this biopsy is adequate and not to miss the diagnosis, we have to do a 2 course, and at least to found 1 glomeruli for electron, 3 to 5 for IF, and more than 6 glomeruli for light microscopy. This is for native kidney, but for the transplanted kidney, it should be 7 to 10 glomeruli and 2 arteries at least. The most confusing part regarding histopathology and biopsy, we have to imagine that you are taking a picture for a man or a woman. So sometimes you take a picture and unfortunately, you take the picture from his back. So it's not clear. You can't see this person is Muhammad or Mustafa or whatever you name it, because unfortunately you take the picture from his back. Also, another point regarding biopsy, it's a static picture. So let's say, as we see down here, this person is falling from a roof. So you can imagine this patient is still in the air while we are speaking, but unfortunately, this patient already hit the ground. So you can't. You have to imagine this patient sometimes did a kidney biopsy since 3 months. And you started treatment. After treatment, you are revising his biopsy, and you say, yeah, this patient has this specific disease, which is unfortunately this histopathology change it now, because it's time related. And we usually see this dilemma in lupus patient, and usually we are considering another biopsy, especially for changing of our management. So don't forget, histopathology is like picture. You have to think what is the most probably the microscopy will give you the very nice and clear picture for this person, because some diseases you have to get a nice biopsy in electron microscopy to get the front picture. And sometimes you have to get a nice glomerular in the immunofluorescent to make a decision and to make diagnosis. And sometimes you will miss the diagnosis if you forget this microscopy. So as we see, it's a photo. Maybe you got unlucky and the main glomerulus is shown in light microscopy, which is not enough for diagnosis, and you miss the electron microscopy. Now you have a picture from his back, and you خلاص stuck. So you can imagine if you did a microscopy and the sample which was sent to the histopathology for immunohistochemistry was unfortunately contained no glooms, you will miss this diagnosis. Because all of this disease present with the same pattern. It's presented with mesangial proliferation. So if your histopathology giving you this patient now has mesangial proliferation in light microscopy, you will be stuck without immunohistochemistry, because IgA nephropathy, IgM nephropathy, C1q, antiglomerular basement membrane disease, fibronectin, fibrillary N, light chain, AL amyloid, all of them present with mesangial proliferation. The main issue for diagnosis, for differentiation, is by immunohistochemistry. So the microscopy will give you the clear picture for the disease is the immunohistochemistry. For another group of disease like minimal change disease, papillary and nail patella syndrome, dense deposit disease, this disease is only diagnosed by electron microscopy. So unfortunately, if you did a kidney biopsy and you get no glooms in electron microscopy, you will never be able to diagnose such a disease. خلاص, finished. You have to do another kidney biopsy, unfortunately. So the only clear picture you will get for diagnosis of this disease by electron microscopy. We have common stains in a light microscopy. You have hematoxin and eosine, boric acid Schiff, mesamine silver, and trichrome, and Congo. I put this slide just to make you clear regarding this point. This is the standard stain. If you didn't ask your histopathologist to do an extra stain, he will never do it. This is the standard. So if you have a patient suspected membranous nephropathy and you want to do anti-plur in his histopathology and you didn't ask the histopathologist, he will never do it, because this is the standard. Once you're asking for extra, you have to ask about it. Also, there is another stain like DNA GP9. Now it's proven for diagnosis of papillary glomerulonephritis. So if you are suspecting papillary glomerulonephritis and you didn't ask for DNA GP9, it's an extra stain with extra money. You have to ask about it to be done. So what is the solution for this dilemma? You have to look for the clinical presentation. If the patient, let's say, we have this patient, 25 years old, presented with nephrotic syndrome. So we are expecting a non-proliferative lesion. So we are expecting like minimal change, FSGS, and membranous nephropathy. If we are cutting the sample, the main category it will be go for electron microscopy, because this electron microscopy most probably will give you a clear picture. And if you can do serological or radiological test just before going for biopsy, it will help. Like, you can ask for serological antiphospholipase A2 receptor antibody. If it's positive, خلاص, you already knows this patient has some kind of membranous nephropathy. If you do go for a kidney biopsy, do it with proper needle, with proper approach, at least 2 courses. You have also to discuss with your histopathologist about your patient before the biopsy. Because as we mentioned, it's not a diagnosis. Histopathology is not a disease. It's giving you a prescription, giving you this patient has mesangial proliferation. What is the underlying cause? He doesn't know. You are the only one who treating the patient. So you don't rely on the histopathology 100%. It will never give you the clue. You have to look for the patient age, sex, presentations, serology, radiology, family history, even his medications. You have to consider what is the most probably the diagnosis before going to the kidney biopsy. Even you can ask for extra stains if you are considering a specific disease like myeloma or something. And Don't forget, biopsy, it's a static picture, not a dynamic picture. So don't rely on a biopsy done with for 1 year. If you consider there is a clinical change in the picture, you can ask for another kidney biopsy. Data recording is a must for the patient, dates, treatment he received in each step. So let's go quickly to our cases. Case number 1, we have 25 years old male patient presented to the emergency with creatinine 600, GFR around 8. He has no previous history of any medical disease. He never went for checkup. He was going for test extraction. Question of the family: does this patient need dialysis? As we agreed before, dialysis initiation based on either absolute indication, or you have to wait. You can wait as long as you are considering recovery for this patient. So early versus late, it's an individualized decision. If yes, is it lifelong dialysis? Lifelong dialysis or not, it's depend on signs of chronicity. You have to look for CKD, MPD, ultrasound, for fundus examination. If the patient going for chronic kidney disease, خلاص, he is chronic kidney disease. You are lucky if you found some kind of acute element. If you are not, خلاص, he most probably he will go for lifelong dialysis. Does he need a kidney biopsy? If the patient is fit, kidney size normal, and he shows some kind of glomerular disease like proteinuria or hematuria, yes, I will go for kidney biopsy. For second case, we have 24 years old male presented with generalized edema. This is a prescription of nephrotic syndrome. We are speaking about a patient came with clinical picture of nephrotic syndrome, proven by urine analysis showing albumin +3 or no RPCs. His creatinine is normal. What is your approach? I have to confirm the diagnosis. We have to do 24-hour urinary protein excretions. You can go for albumin create, protein create just for follow-up. You have to ask for another investigation like ultrasound. You have to assess immunological workup. If you are considering this patient maybe a membranous nephropathy, you can ask for serological antiphospholipase. And do you need a kidney biopsy? If the patient proven to have nephrotic range proteinuria, yes, I will go. For subnephrotic, I have 2 options. I can wait until if the patient is clinically stable, can start ACE or ARBs, close monitoring if this patient, if I considering some kind of tubular injury, like patient received the non-steroidal, so maybe I will wait. But for nephrotic syndrome, no, I will go ahead for kidney biopsy. As an elective, because this patient has normal GFR and is presentation with plant urinary sediment. What is the expected pattern? We are expecting a non-proliferative pattern. We are expecting like epithelial lesion. So what is the most important microscopy? All of them are important, but for the most important will be the electron microscopy. Put a referral, I will put a clear referral, 24 years old, mentioning every single details of the patient to the histopathology. And even I can call him in the phone and discuss the case and put the differential diagnosis to reach the most probable diagnosis. Summary: don't forget chronicity-related symptoms and signs. You can rely on to differentiate between acute kidney injury and chronic kidney disease. Decision of kidney biopsy based mainly on urine analysis. Hematuria, we have 2 kinds of hematuria: dysmorphic hematuria and normal shape biconcave hematuria, which is extraglomerular cause. Proteinuria, it's we have to assess whatever quantitative or semi-quantitative. Gold standard 24-hour albumin creatinine can be used for follow-up. Decision usually preferred to be done over 24-hour urinary protein. Don't forget, we have 5 clinical syndrome in glomerulonephritis. We have nephritic, asymptomatic urinary sediment. We have rapidly progressive glomerulonephritis and patient presented with chronic GN. Histopathological pattern, it's a pattern. It's just prescription. It's not a disease. So if you can see like FSGS, focal segmental glomerulosclerosis, or membranous nephropathy, it's just a pattern. It's not a final diagnosis. Kidney biopsy and how to interpret it. You have to have sufficient biopsy. If you have a patient with proliferative lesion, non-proliferative lesion like minimal change, considering as a minimal change and don't have any electron microscopy, you will never be sure about the diagnosis. And treatment, as I mentioned, blunt urinary sediment is elective, and for a patient with proliferative lesion with active urinary sediment, it's an emergency. And finally, thank you.